Bronchiectasis. Bronchiectasis. First, we'll talk about anatomic alterations. Anatomic alterations. Varicose bronchiectasis. Varicose bronchiectasis results in dilated and constricted in an irregular fashion similar to varicose veins and ultimately resulting in a distorted bulbous shape. Cylindrical or tubular bronchiectasis are bronchi that are dilated and rigid and have irregular outlines similar to a tube. Saccular bronchiectasis or cystic bronchiectasis are bronchi that progressively increase in diameter until they end in large cystic-like sacs in the lung parenchyma or lung tissue. This form of bronchiectasis causes the greatest damage to the tracheobronchial tree. Also shown are excessive bronchial secretions and atelectasis, which are common anatomic alterations of the lungs in this disease. In bronchiectasis, there is chronic dilation and distortion of one or more bronchi. This is usually a result of extensive inflammation and destruction of the bronchial wall cartilage, blood vessels, elastic tissue, and smooth muscle components. One or more lungs may be involved. This is commonly limited to a lobe or segment and is frequently found in the lower lobes. The smaller the bronchi and ones with less supporting cartilage are the ones that are predominantly or mostly affected. Let's look at the REID classifications of bronchiectasis. Varicose or fusiform bronchiectasis are bronchi that are dilated, as we've said before, and constricted in an irregular fashion similar to varicose veins. They're distorted and bulbous in shape. Cylindrical or tubular bronchiectasis are bronchi that are dilated and rigid and have regular outlines similar to a tube. Cystic or saccular bronchiectasis are bronchi that are progressively increase in diameter until they end in a large cyst-like sac in the lung tissue. This is a picture of cylindrical bronchiectasis in the posterior lower lobe. This is from a bronchogram. You can see some in the superior segment, but most of it is in the lower lobe, and it's a common finding in bronchiectasis. This is cystic or saccular bronchiectasis from a right lateral bronchogram. It shows bronchiectasis affecting mainly the lower lobe and the posterior segment from the upper lobe. Varicose bronchiectasis. Varicose bronchiectasis in the left posterior oblique projection of the left bronchogram in a patient with ciliary dyskinesia syndrome. All basal bronchi are affected by varicose bronchiectasis in this bronchogram. You can see the irregular outline from the varicose bronchiectasis. Major pathologic or structural changes. Major pathologic or structural changes include chronic dilation and distortion of the bronchial airway, excessive production of foul-smelling or purulent secretions, infected secretions, bronchospasm, hyperinflation of the alveoli, air trapping, atelectasis, consolidation and parenchymal fibrosis, which is permanent damage, hemoptysis secondary to bronchial arterial erosion. Etiology and epidemiology. Most causes of bronchiectasis include some combination of bronchial obstruction and infection. In developed countries like the United States, Canada, and England, cystic fibrosis is the most common cause of bronchiectasis in children. However, we want to talk about the prevalence of non-cystic fibrosis bronchiectasis, or NCFB. It is relatively low, about 4.2 per 100,000 young adults in the United States. The low incidence is often attributed to early medical management. Causes of bronchiectasis are commonly classified by why they happen, such as acquired bronchial obstruction, congenital anatomic defects, immunodeficiency states, abnormal secretion clearance, miscellaneous disorders, such as alpha-1 antitrypsin deficiency. You can see the full list of this in Table 16.1 in your book. This is on page 261. Diagnosis. A routine chest X-ray may reveal such findings as overinflated lungs or marked volume loss, increased opacities, as in pneumonia, dilated fluid-filled airways, crowding of the bronchi, or atelectasis. Although bronchoscopy is now rarely performed, bronchograms can confirm cylindrical, cystic, or varicose bronchiectasis, as you've seen. It can also show the loss of bronchiovascular markings, and in more severe cases, honeycombing, air fluid levels, and fluid-filled nodules. Bronchoscopy at one point in time was the absolute gold standard for the diagnosis of NCFB. Today, however, high-resolution computed tomography, or HRCT, has virtually replaced bronchiography. It is now the best tool for diagnosing NCFB. The diagnosis is made on the basis of the internal diameter of a bronchus, and it looks at if the bronchus is wider than its adjacent pulmonary artery, a failure of the bronchi to taper, and the visualization of a bronchi in the outer 1 to 2 centimeter of the lung fields. The HRCT scan is used to better clarify the findings from the chest X-ray and the standard CT scans, and allows lung mapping of airway abnormalities that cannot be identified on routine films of the chest. Spirometry testing is used to determine if the bronchiectasis demonstrates obstructive or restrictive lung disease, and arterial blood gas measurements confirm if a patient has mild, moderate, or severe gas exchange abnormalities. What will you see at the bedside? Excessive bronchial secretions, bronchospasm, which creates wheezing, consolidation, which you may hear crackles, and increased alveolar membrane thickness, which can result in a lower P(a)O2. What data will you obtain at the bedside? You may create an obstructive or restrictive lung disorder are a combination of both, depending on the amount of bronchial secretions that are retained and the degree of bronchial destruction. Also, fibrosis or atelectasis associated with the bronchiectasis will play a role in whether the bronchiectasis creates an obstructive or restrictive lung disorder. Physical examination. Vital signs will be increased. You will see tachypnea, or increased respiratory rate, tachycardia, increased heart rate, and an increased blood pressure. Use of inspiratory muscles, use of accessory muscles of expiration, and pursed lip breathing when the pathology is mainly obstructive in nature are common findings. Increased anterior posterior chest diameter or barrel chest when the pathology is obstructive in nature, cyanosis, which is a late sign of hypoxemia, and digital clubbing, which means hypoxemia has been around for many, many years, are also common physical findings in your examination. Peripheral edema and venous neck distension is also common. Pitting edema in the ankles and hands and an enlarged and tender liver are very common findings. Cough, sputum production, and hemodynamics. Chronic cough with production of large quantities of foul-smelling sputum is a hallmark of bronchiectasis. Hemoptysis is often present from broken arterial blood vessels in the lung. When the pathology is primarily obstructive in nature, you will have decreased tactile and vocal fremitus, a hyper-resonant percussion note, diminished breath sounds, possibly wheezing, and possibly crackles. When the bronchiectasis is primarily restrictive in nature, over areas of atelectasis and consolidation, you may have increased tactile fremitus and vocal fremitus, bronchial breath sounds, crackles, whispered pequililoquy, and a dull percussion note. Let's talk about some of the pulmonary function testing results that you may see. First, we're going to talk about obstructive results. Forced expiratory volume and flow rate findings. You may have a diminished FVC, a diminished FEV1, a diminished FEV1 to FVC ratio, and all flow rates may be diminished for obstructive, moderate to severe bronchiectasis. Now we'll talk about lung volume and capacity findings for obstructive bronchiectasis, moderate to severe. Tidal volume, IRV, ERV, IC, and total lung capacity, as well as RV to total lung capacity, all may be normal. FRC and RV may be increased. If the RV is increased, then that may affect the FRC and the total lung capacity. When the pulmonary function test reveals a restrictive nature to the bronchiectasis, the flow rate findings may show a diminished FVC, a normal or diminished FEV1, a normal or increased FEV1 to FVC ratio, a normal or diminished FEF 2575, a normal or diminished FEF 50, a normal or diminished FEF 200 to 1200, and a normal to diminished peak flow, as well as MVV. Lung volume and capacity findings when the bronchiectasis is primarily restrictive in nature may all be diminished. The RV to TLC ratio may be normal. In mild to moderate bronchiectasis, arterial blood gases reveal acute respiratory alkalosis with an increased pH, a decreased PaCO2, secondary to an increased respiratory rate. Bicarb is normal, but a low normal, and PaO2 is low, as well as a low oxygen saturation. Arterial blood gases in severe bronchiectasis reveal chronic ventilatory failure with hypoxemia. This is a compensated respiratory acidosis. In a compensated respiratory acidosis, the pH is normal. The PaCO2 is increased. The bicarb is elevated significantly to compensate and bring the pH back to normal, though it's the acid side of normal. The PaO2 is chronically low, as well as the oxygen saturation being chronically low. Let's talk a little bit about acute on chronic ventilatory failure. Because acute on chronic ventilatory changes are frequently seen in patients with chronic ventilatory failure, the respiratory therapist must be familiar with and alert for the two following dangerous arterial blood gas findings: acute alveolar hyperventilation superimposed on chronic ventilatory failure, which leads to possible impending acute ventilatory failure. Acute ventilatory failure, acute hypoventilation superimposed on chronic ventilatory failure. These both may necessitate intubation and a ventilator. Oxygen indices with moderate to severe stages of bronchiectasis. Hemodynamic indices with moderate to severe stages of bronchiectasis. Abnormal laboratory tests and procedures. An increased hematocrit and hemoglobin is a common finding in bronchiectasis, as well as an elevated white blood count, especially if infection is present. Sputum examination often reveals Streptococcus pneumoniae or Haemophilus influenza, Pseudomonas aeruginosa, or anaerobic organisms. Radiographic findings. A chest radiograph, when bronchiectasis is primarily obstructive in nature, will show translucent or dark lung fields, depressed and flattened diaphragms, a long and narrow heart pulled down by the diaphragm. It may show a enlarged heart when heart failure is present, and areas of consolidation or atelectasis may or may not be seen. There may be tram tracks also present, as shown in this X-ray. When the bronchiectasis is primarily restrictive in nature, bronchiectasis, atelectasis and consolidation, and pulmonary infiltrates suggesting pneumonia, increased opacity will also be present, as shown in this X-ray. General management and treatment of bronchiectasis. The treatment of the underlying disease may not be possible. For most causes, the treatment of the underlying disease is impossible. Exacerbations are commonly caused by acute bacterial infections, and the general treatment plan is aimed at controlling pulmonary infections, airway secretions, and airway obstruction and preventing complications. Antibiotics, tailored to the patient's sputum cultures and sensitivities, bronchodilators, and expectorants, are often prescribed during periods of exacerbation. Daily chest percussion, postural drainage, and effective coughing exercises to remove bronchial secretions are routine parts of the treatment. Childhood vaccinations and yearly influenza vaccines help to reduce the prevalence of the infections. Avoidance of upper airway tract infections, smoking, and polluted environments also help to reduce susceptibility to pneumonia in these patients. Surgical lung resection may be indicated for patients who respond poorly to therapy or a VAT procedure. These are also indicated for patients with massive hemoptysis. General treatment plans include the control of pulmonary infection, airway secretion, preventing complications, antibiotics, bronchodilators, expectorants, CPT, and vaccinations. Respiratory care protocols that you'll see. Oxygen therapy protocol. Oxygen is used to treat hypoxemia, decrease the work of breathing, and decrease myocardial work, or the work of the heart. The hypoxemia that develops in bronchiectasis is usually caused by pulmonary shunting associated with the bronchiectasis. The hypoxemia may not respond well to oxygen therapy when true or capillary pulmonary shunting is present. Airway clearance protocol. A number of airway clearance modalities may be used to enhance the mobilization of secretions, including directed cough, exercise breathing programs, autogenic breathing, forced expiration, chest physiotherapy, suctioning, positive expiratory pressure or PEP, oscillating PEP, such as flutter valve or a cappella, high-frequency chest wall compression, like the pneumovest, lung expansion therapy. Attempts to keep the distal lung units inflated may involve the use of deep breathing and coughing exercises or incentive spirometry. Aerosolized medication therapy protocol. Both sympathomimetic and parasympatholytic agents are commonly used in selected patients with bronchiectasis to induce bronchial smooth muscle relaxation. Sympathomimetics are albuterol, and parasympatholytics are albuterol and Atrovent combos are commonly used in selected patients with bronchiectasis to help relax bronchial smooth muscle. The use of corticosteroids is discouraged because we just don't have enough data. Dornase alpha acetylcysteine may also be used, but many centers require the use of direct physician order for them. Mechanical ventilation protocol. Invasive and non-invasive mechanical ventilation may be necessary to provide and temporarily help improve alveolar ventilation and eventually return patients to their baseline condition and/or spontaneous breathing. Thank you so much for your time and attention, and I hope to see you again.